Good afternoon. My name is Dustin Geverlow, Managing Director of the North Dakota Watchdog Network, and today I am speaking with Peter Fjelstad. Is that the word?
Fjelstad, the J like a Y, a nice Norwegian name. My
Okay.
family's still in North Dakota, so
For full disclosure, would you tell us your title and all that?
sure. My name is Peter Fjelstad, and I'm a Senior Director for State Policy at PHARMA, and that's the Pharmaceutical Researchers and Manufacturers of America. We're a trade association of 33 brand name biopharmaceutical manufacturers, so brand name only, not generics.
Okay. Okay. Good to know. This session, there have been, I believe there's 4 total bills that are looking at ways of, at the state level, controlling the prices of prescription drugs. And obviously, this has been a long-standing issue. 20 years ago, this was Byron Dorgan's pet project at the national level. Donald Trump took on this cause as part of his populist messaging. And so it then somehow became a Republican issue, which is kind of interesting on how quickly that flipped. And so we've got several bills, Senate Bill 2209, Senate Bill 2170, Senate Bill 2212, and then House Bill 1032. And they're all kind of going in the same direction, which is one of them wants to piggyback on other states and let other states create a importation program where American states would buy drugs out of Canada, thinking that they are going to get some sort of a reduction. First of all, I'd like to address one issue that I always bring up in this is why do people think that Canada would want to allow us to do this in the first place?
Dustin, I think that's a great question because during the testimony specifically on the two pure importation bills, 2209 and 2212, there were Canadian residents and officials that spoke out in opposition. Canada, unlike the United States, the healthcare system is very different, and it's really an apples and oranges comparison. I'm from Minnesota. A lot of families still in North Dakota, and Minnesota and North Dakota, they have different programs, private programs, but that takes seniors and buses up over the border to get meds that are discounted. But those hearings on the 2 North Dakota importation bills, those officials don't want to have what's yet to be any successful state program for importation of drugs from Canada to those states, and being in a border state, North Dakota, it's more on top of people's minds. They do have drug shortages in North Dakota, and that's something we don't really have here. We're a hotbed of innovation. You just look at what's happened with the COVID vaccine and other drug breakthroughs, and that wasn't always the case. Not really until the 1980s did the United States become that way with biopharmaceutical development, and that's because we changed a lot of our system to lift restrictions on companies doing the research and development and ultimately the distribution of drugs. And so these Canadian officials, they don't want to have states set up importation programs for many reasons, and also the fact that they have an extremely small closed system, and there's a lot less people in Canada than there are in the United States with different needs. They have a different delivery system of care, and so anything to mess with that, they just don't want to deal with. One side note, they have a specific board, a federal Canadian board, and that manages and restricts certain price increases for brand name drugs in Canada. In turn, they don't have that type of regulation for generics. So generics are actually more expensive in Canada than they are in the United States. And in the United States, 90% of Americans get their drugs via generics. And so that's kind of a separate issue, but that's kind of a long-winded answer to your question. The systems are apples and oranges, especially when you talk about the importation issue and these Senate bills 2209 and 2212.
Yeah, because Canada has a mix of hard price caps and then also subsidies. And so, and I don't know the exact details of that, and I'm sure it's a drug by drug basis, actually, depending on what its purpose is and that sort of thing, how elective it is, those sort of factors that come into it. But it really is. I mean, I know that Canada initially, when we had these busloads of people going up there, they were pushing against that on a personal, 20-person at a time level. So this idea that somehow they're going to want us to come in and raid their supplies is really not. It's just not logical, really, when it comes down to it, because as you said, they're a much smaller country, and so they've got their form of socialism, which is kind of a Scandinavian form of socialism, and that sometimes works when you have a lot of revenue from some specific industries and not a lot of people to take care of. So that there's reasons that those systems work in those countries more than it would work here. And one of the things that always comes up is that people ask, well, why are drugs in America so much higher than other countries? And part of it is because, at least this is what I've always been told and what I've repeated in the past, is because these other countries control the prices, we have to pay the difference. Is that accurate, and how accurate is that?
I don't know. I think unfortunately it's a gray area to answer that question. The reason is, again, when we were seeing apples and oranges between the Canadian healthcare system, including pharmaceuticals in the United States, it's also the same for that, and us subsidizing them. We don't have the type of backlogs, both in wait to see a specialist or a primary care doctor or refilling of prescriptions, and they're limited in the raw materials that they have in Canada to produce. And so most of their manufactured drugs come from other countries. Now, that's not the case in the United States. Most of the drugs that people consume in the United States are actually made from materials here, but we do have a very diverse supply chain throughout the country. The fact of the matter is there's just a lot of different entities in the United States supply chain versus what is in Canada, where it is, as you said, socialized medicine or a single payer system, one of two really prominent ones, the other being the United Kingdom of single payer healthcare. In the United States, drugs overall for brand name medicines have only increased 1.7% in 2019. That's the recent data we have available, and that's below inflation for the third year in a row. So to answer your question, hopefully it's not too indirect way, the problem really is with some of these outstanding cases in North Dakota and other states where individuals have rare conditions or really expensive conditions that necessitate extremely expensive care. And that sometimes that extremely expensive care is in a drug therapy or the consumption of a drug. And those are the types of outline issues that make their way. Those patients, they contact their legislator and they want to know what can be done about it. We always say the rebates that we provide to patients get eaten up, and not to point fingers, but by the health plans, the insurers and the pharmaceutical benefit managers, or PBMs, because frankly, if all the rebates that the manufacturers, our member companies, made available for patients to drive down the costs they pay at the pharmacy counter or for their mail-in pharmacy, they'd see a dramatic reduction right away. And there's bills we've had in North Dakota and other states that have passed legislation to really get at that issue and figure out what's going on. One of the bills that we're going to talk about today is 1032, and that is providing transparency across the supply chain. So it's not just on the people that PHARMA represents, the manufacturers, but the wholesale distributors who then send them to the pharmacy, and on the pharmacy and the hospitals who provide them to the patients, and on the health plans and the PBMs, so people can really see where the money's going, especially those rebate dollars. So hopefully I kind of painted somewhat of a picture, but I also wanted to talk about these importation issues. One of the biggest concerns is safety. And that's not only what the Department of Homeland Security and sheriffs in North Dakota have said, but also Canadian. We've talked about strengthening borders, and especially under President Trump, and doing these type of importation bills, these plans under them. No other state's been able to guarantee the safety required under the federal law that President Trump signed to make these importation programs a reality. The rule basically said they left it up to the states to determine how to make sure that the ingredients in the drugs, as well as any sort of narcotics trade as a result of it, or bootlegging, for lack of a better term, was all going to be safe. And no state's been able to do that, including North Dakota, as a result of these bills.
Yeah. So getting to the price issue, how much of what people see on their receipt and what people hear about on the news of, thousands of dollars a month, those sort of situations, how much of that is middleman upcharging? And is there anything that states can do about that, or is that entirely federal?
Both. It's both, and it depends on the type of health plan you have. So, we've got legislation in different states that we've pushed in North Dakota. I know for the latest numbers I have available from 2018, we spent 166 billion in 2019 on rebates. 2019, but then 37 million was rebated back to the state of North Dakota. And so that's the latest figures I have available. So that pot of $37 million that goes back to, residents or consumers in North Dakota, we don't have a lot of visibility in how that's going to somebody that works for an employer-based, that has an employer-based health plan. The employer pays a certain share of the premium and moves the deductible around, and the co-pays and the co-insurance. But what we'd like to see is how much of that $37 million, or, for their updated numbers, what those are going to be for the 2020 numbers when we get them, how is that being distributed to the patients specifically that should be receiving those? So I know that we've got that big number. I just don't know how it's hitting people at the counter.
Okay. Now one of these bills, it is, which one is this? 2170 is the reference pricing concept of pegging our prices and installing price controls at the North Dakota state level, commiserate to and based on prices in Canada, specifically British Columbia, Alberta, and Quebec, the Quebec Public Drug Price Program.
Yep.
So, the first thought is whenever you get price controls, obviously you're going to have supply issues. And secondly, why would North Dakota, or why should they not be tying their own hands to what the Canadians are doing? It doesn't seem to be logical to create a price cap, but not actually control the prices yourself.
Yeah, it's interesting. And I know that bill, the 2170, is very troubling. It didn't come out of a vacuum, I can tell you that. And I know that it's been amended as far as now it wants to put the burden on the North Dakota Insurance Commissioner to actually negotiate the prices, and that's something he's not going to want to do. In fact, if you looked at the NDPERS, the retirement system fiscal note, as well as the testimony of the executive director on 2170, this bill, they can't substantiate any savings to the state or consumers, any fiscal impact that it's going to have, because of how strange and bizarre the language is. It is a price control, but they can't figure out how is this going to benefit not only the state, but also North Dakotans? And he also specifically highlights that the fact that you'd put a price control based for North Dakota drugs based on what's happening in a few different federal provinces in Canada. Again, that's apples to oranges, and people's needs are different, and it's going to restrict access. I mentioned that this didn't happen out of a vacuum. There's an organization called NASHP, and that's short for National Association of Health Policy, State Health Policy, and they're an organization that's supposed to be nonpartisan, but frankly, they're not. At the hearing on 2170 at the end of January, a gentleman named Drew Gattine, that's Gattine, spoke in favor and was represented in the committee as basically a neutral party and a nonpartisan observer. And he's been the primary driver in other states, Maine, Rhode Island, Hawaii, and even Oklahoma, the only other red state that's seen any action on this bill besides North Dakota. And he is not only a current state rep, Democrat in Maine, he's also the chair of the Maine Democratic Party. And Mr. Gattine makes appearances around the country for this issue in an attempt to put price controls into different state systems. And so we think that's a dangerous political agenda, and he's trying to remove the competitive free market based on his ideology of what he thinks works, which ideology doesn't always match reality. And so there is that interest group, and it's pushing, and they talk to legislators all over the country, including in North Dakota, and that's where this language came from. And I can't think of any more devastating a thing for North Dakota patients to have a price control or restrict the access to their needed medications, when in the vast majority of the time, people are either taking generics or they're taking brand medicines that they can afford. It's these outline, and again, they're terrible cases of patients that are having to pay too much money for their drugs. And that's, we would argue, is a result of middlemen not applying the rebate to the patient's cost at the counter.
Does Maine have language in their code that is based on triggers determined that will be triggered by other states adopting this language? Is that his motivation?
No, they have. So Maine, Rhode Island, Hawaii, 3 blue states are pushing the same legislation, and then North Dakota and Oklahoma are the 2 red states. And Maine right now, under Gattine's guidance, is trying to push this bill. Interestingly enough, the Maine was one of the first states a few years ago before the Trump order kind of drove the issue even further, but tried to, they border Canada too, and they tried to enact an importation program. However, they had no success with it, and they passed legislation and got down the road. But every pharmacy in the state, mom and pop, and the big ones that did mail-in, they couldn't figure out a way to make it work. And so, it's another way of comparing apples to oranges, that our system is much more free market driven. And again, there are instances of these higher costs, but overall, that's just not the case.
Yeah, there's always some underlying motive. Now I'm going to jump to House Bill 1032, and this is the one that I'm least exposed to, because I was keeping an eye on the Senate ones, and this one is interesting because it did come out of the Health Care Interim Committee. Mm-hmm. Which gives it a little bit more heft than the other bills, and obviously it makes it a little bit tougher to defeat. And so this one is related to the benefit manager issue. Is this the? Well, why don't you give me your take on 1032?
Sure, 1032. People understanding and being able to understand what they're going to pay, especially upfront, is always a good thing. And we think healthcare, unfortunately, including prescription drugs, you can't, with the PBMs and the health plans involved to eventually adjust the prices. If you've got a health plan, you can't always know going in, oh, I thought this is only going to be $20 and now it's $75. And this bill does have a lot of good language because it shines some sunlight onto those types of issues and would help North Dakotans understand things better as far as what they're getting themselves into and how they can understand costs up front. Just the problem with it is, I give an analogy to a bill that happened in a law that was enacted in Minnesota a couple of years ago, and that was just due to healthcare or hospital costs. So it was put in law to require specific healthcare costs in a hospital stay and different thresholds, triggers, whatever, to be required to be sent by the hospital to a patient. So if you go in and your wife has a baby, you could get that. So I actually took advantage of it. And what I got back was a 30-page packet of every single line item of coded stuff, because they all use codes, not layman's terms or, real English. And it's stuff that I just didn't understand. So the worry that we have, especially on the manufacturing side with the bill, is that you're going to provide people with all sorts of information that, one, isn't going to bring down the cost of drugs if that's the intent of the bill, and two, the interpretation of what kind of publicly available data that the bill ultimately requires. People might not be able to interpret that, and it could just be a data dump, and people might be more confused than usual. But again, we do like the fact that the bill has transparency on every actor in the supply chain. I talked about the manufacturers to the distributors to the pharmacies to the hospitals who distribute a lot of drugs. And a lot of times they upcharge them, as well as the PBMs and the health plans, who, you look at a statement, you can see on your explanation of benefits how the insurance adjusted it. So that's the price everybody ultimately pays. But it is concerning because I don't think that the transparency issue overall is going to bring down healthcare costs.
Well, that's interesting, because that was, of course, one of the primary arguments that those of us who fought Obamacare originally used, was the upfront pricing was one of the key tools that would fix things without government interference. I traveled the state for about a year fighting that, doing town halls and press conferences and all that stuff that everybody did. I was part of the U.S. Chamber's effort here in North Dakota back in 09 and 10 on that. And, the transparency has to be understandable, so there's got to be somebody who interprets it and puts it into language. That the ideal is, a McDonald's menu type of approach, where you can actually figure out what you're getting and what you're paying for, and that sort of thing. But nobody in the system really wants to do that, it seems. And whether they can, I mean, they got to hire new people to be able to pretty it up a little bit so that the regular person can read it. I think that the overall I've had issues on this with getting charged $3,600 for an IV. It's like, what?
Yeah.
And I understand contingency pricing and all that kind of stuff. So, I mean, the average person may not. It's kind of like the old Department of Defense $600 hammer and $2,000 toilet seat. Well, because they don't do contingency pricing, they got to put the overcharge in somewhere, and it ends up being in the most ridiculous thing possible. And then those get all the attention, and everybody thinks that's a illustration of the inflation going on everything.
Right.
And then when you do get that bill, you got to fight it. It's like, okay, I was there for 4 hours. There's no way I used $3,600 is going to buy me a truckload of IV bags. I know that.
Yeah. Or one Advil for $8 or something like that.
Yeah.
I've no family in my family have seen and wonder what the heck's going on. But I'll give you an example just on that transparency issue. Minnesota passed a pretty big 2020 law on transparency, and it's only on manufacturers. They didn't put anybody else in the supply chain, which in our opinion certainly makes no sense because there's so many actors. But the data that they're collecting from the manufacturers that do business in the state, again, this law was passed in May and signed into law. They're not even collecting the data until October 1st of 2021. So 7 months from now. Then the Department of Health here has 3 or 4 months until the middle of January to take all that information and their quote unquote experts distill it down and analyze it into a way that a legislator or anybody could understand. But that said, they're still putting more, they're still trying to pass more of these quote unquote transparency, which we really view. We try to use the term reporting, mandatory reporting when we can. They're still trying to push this session more reporting on us, even before we've already replied to the information from 2020. So I think it's just piling on, and it sounds good in a soundbite, and it's good politics by Twitter and social media without resolving the issue.
Yeah, and that's kind of where Senate Bill 2212 that ended up as a study, and they passed that. And my guess is that even if the rest of the bills were to get defeated, the study would still go forward, and then it's a matter of you guys doing your work in between.
Right.
But now we've gone through all of the reacting to what is out there. Are there any documented proposals by industry that states could take on to actually address this in a way that wouldn't make it worse, other than the obvious, reducing corporate tax and the generic stuff that we always talk about? Are there any specifics, any outline 7-point plans that are out there already that states could grab on and start discussing?
Yeah, absolutely. We've got what we call our proactive policies, meaning things that we think are really going to help people going forward with driving down their rates, what they pay out of pocket. And we just call it patients pay less. I'll give you an example. There's a couple states in the Midwest, but there's been 5 states that have so far passed it, including red and blue states. But I guess Georgia's purple now, but we'll see. And Arizona and West Virginia, along with some others. And we call it an accumulator ban, and it's also count the coupons. So what health plans have now, and they deal around with their deductibles and the coinsurance and the copay, they get the rebates or coupons from us, and they apply them not towards the cost of the drugs that their enrollees, their consumers pay at the counter or for their mail-in drugs. They put them into what they call an accumulator program. And that is, say you've got within your written policy, you've got a piece of it that they would call their accumulator program, and all the coupons that the manufacturers send get pushed into that rather than going towards a deductible or towards the lowering the overall cost of your medicines. And so we've got 5 states that have passed that so far. We've also got instances where we're looking to get states interested in requiring their health insurance plans to offer options with a fixed dollar drug copay. They wouldn't have to do it for a majority or even a lot of them, but just require them to offer at least one plan with a fixed copay or no deductible, in addition to the other plans they offer in the states. So we've got a menu of these issues that we work that have been successful in blue, red, and purple states, that have been put into law and that we're currently pushing all around the country. And so, I think that if people really knew, especially North Dakotans knew how much coupons were getting tied up into the system and not being passed on to them by the manufacturers, I think they'd be even more up in arms than they are about the costs that they have to pay.
So are there existing laws that are preventing the manufacturers from being able to apply those coupons and rebates at the retail level?
What really happens is, we've got a wholesale acquisition cost that we set with a distributor, and there's 3 companies that control basically the distributing in the country. They buy it from us, they sell it to the pharmacy and or hospital to distribute. And then when most people have an employer-based plan. Some people are on public programs like Medicare or Medicaid, and some people buy their individual policies, especially if they're self-employed. So then after they're in a pharmacy or a health plan, they run them through a system And that then shows, based on the person's contract with the health plan, which is contracted with a PBM, which they often own, then they adjust that price that the person pays at the counter based on that contract language. And so there's really not there's not any law that would require either federally or the state to show specifically how much a North Dakotan should be receiving of the coupon that the manufacturer puts as a part of the product into the marketplace.
So those coupons and rebates, when you say they accumulate, do they accumulate for that specific drug, or do they accumulate for the whole pie?
They would accumulate for one individual's health plan. So you might be taking 3 or 4 drugs, and that would all go into your individual accumulator in your health plan. If you're taking one drug, that all go in. If you're taking 10, it all go into that same pile for each individual's health plan. And then it could be different if you're on a family policy. I've got a wife and 2 kids. And so it all depends on what the contract your pharmacy, it all depends on the contract that your employer signs with your health plan, and then the contract that they sign with their PBM, which again, most of the PBMs in the country are owned by the health plans. So,
okay, so there's a lot of averaging of costs that are going on that are probably. Would it be safe to say that the high-priced drugs have the highest coupons in general?
That can happen, and it depends on the individual manufacturer, though, because different manufacturers provide different levels of coupons based on the demand for the drug, the cost that it took to develop the drug, which is billions of dollars, because the most drugs go through extensive clinical trials, and the vast majority of them fail. The vast majority of them fail. So it's based on a myriad of factors. Unfortunately, it's opaque, but you can dig down, you can figure out what it is and where they're coming from. I should probably highlight a few more that we've got. We've got co-patient cost sharing. So these are more of these proactive policies, a few more. So patients with commercial health insurance, like you buy an individual policy or you've got an employer-based plan, just because of the fact that most people in North Dakota and other states are facing increasing out-of-pocket costs for medicines. They got growing deductibles, co-payments, and co-insurance. It acts as now a barrier for access to their medication. So we think that cost sharing shouldn't be so burdensome that it prevents patients with insurance to accessing necessary medicines. So that's one issue. I think that we also are looking to have people make sure that they're covered in North Dakota and other states, coverage for their medicines from day one. A lot more now. People move around in their jobs and they get different health plans, which is based on a set of contracts. And insurers are increasingly requiring patients to pay high deductibles, like I was saying, before receiving the coverage, the actual coverage for their medicines. Everything's going to the deductible before the insurance kicks in. So again, this can lead to them rationing or not taking their medicine at all. And we don't think that they should have to pay a deductible at the pharmacy counter, and should have at least some of their medicine from the day that they're covered by their health plan, covered from day one. And that leads to predictability for the patient. I think that we just want to make sure that the middlemen like the PBMs are sharing the savings. Again, that these rebates are being, I'm using the term rebates and coupons interchangeably, that they're being passed down to people at the counter to realize these costs. Healthcare is weird because, we make our member companies make a product, they put it into the free market or into the marketplace of North Dakota, the United States. And then you've got all these other individuals taking a cut out of the coupons in order to realize a profit for themselves rather than passing it on to the consumer, which is the intent.
Yeah, and I'd say the corollary is probably the alcohol distribution system. The three-tiered system is the closest to that, and your system is probably even more complicated than that. It sounds like you got 4 or 5 tiers at the end of the day.
Yeah, but that analogy makes sense. I know what you mean, and yeah, it probably is more complicated because most people don't need alcohol to live, but some people need a lot of people need certain medications to live, and if not to live, to at least function as a normal adult and live day to day and be able to function. So
Yeah, there seems to be it is weird that these bills are being so effective and so far in North Dakota, because we're as red as you can get. We're very much against socialized medicine and all that, but now we've got I mean, if you just looked at what passed and by what the margins it passed, you'd think that we had imported a bunch of Minnesota folks.
yeah, no kidding. The price control bill, the Canadian reference pricing, the Canadian price control bill, I think that passed by only a few votes because there's so much concern, and there was all the haggling over getting the insurance commissioner involved to negotiate on stuff. But our industry and we understand that there's these outlying cases, and legislators need to be responsive to their constituents, especially in not being able to afford a medicine is a horrible thing. But there are the outlying cases. Most drugs are generic, as I said before, and most people are afford to take their brand name drugs when they're able to take them. And most of those people, and they're not most, a lot of those people in North Dakota that have to take medicines daily, a lot of them are seniors, and a lot of them are covered under prescription Medicare Part D, which is federal law. And so there's so many different actors and variables in these specific situations. It doesn't always come out in hearings in Bismarck or other states. What's really going on? Why these people are having to pay this amount? Are there advocates? Is there money behind them? Like in the case of, I was talking about Nashby, the head of the Maine Democratic Party, who's been out there pushing all these things. I just want to say, it shouldn't be surprising to people at the Watchdog that that a lot of these people for Nashby or liberal activists, there's a man named John Arnold who's a billionaire, and he and his wife fund a lot of left-wing things throughout the country. But one of their things is spending millions of dollars to advocate for greater government control over healthcare, and they've been a big pusher behind these types of legislation, and they've been a big proponent and a lot of money behind Nancy Pelosi's prescription drug price control legislation at the federal level over the past few years. And so, I think it's always great if people come into these debates with eyes wide open on who are these players, where is this stuff coming from, how does this help me, who's really going to, make out from having something like this. And it's Nashby and people like this guy, John Arnold. So they're also pushing, Nashby's also pushing it, besides this importation and the price control for Canada, they're also pushing bills to have in Minnesota, and I haven't yet seen in North Dakota because I follow all the North Dakota legislature and legislation pretty closely, affordability review or cost control commissions. And that bill is being moved in the Democrat controlled House in Minnesota. It's not going to go anywhere in the Republican controlled Senate, the only split legislature in the country for the next 2 years again. But I can't think of anything that would restrict patient access to medicine than a big state bureaucracy that puts a price control and makes determinations on what drugs can be and cannot be basically sold in the state. And so it's the same people behind all these bills.
Yeah, and it would seem to me that it would be more cost effective on both sides of the ledger, both on the state side and on the industry side, to just come together and develop some sort of a compassionate program where, if your drug is a life and death situation and it's keeping you, from having the terrible side effects of chemotherapy or something like that, let's address those cases. Let's actually target who we're trying to target and not have broad approaches that end up making things worse for everybody.
Yeah, the law of physics. Unfortunately, sometimes in politics, every action doesn't have an equal and opposite reaction. Unfortunately, the reaction is sometimes way worse than the proposed action. And you know, again, it's unfortunate that these things happen, but our industry has, I think at last count, over 950 by every manufacturer of the 33 we have, over 950 custom tailored patient assistance programs that the manufacturers will sign patients that need those brand name drugs up for. Um, and they've thought of just about every scenario for every drug. I don't know that everybody knows about them, that takes those drugs, but they're there and they're private industry sponsored, and they're in a big attempt to get around this log jam of getting the coupons onto those patients that deserve them.
Yeah, and I would assume that a lot of those are the big name drugs that actually are the lifesaver drugs. Those companies don't expect to probably make it all back anyway. It's kind of a loss leader thing. You develop, it's part of the brand. You have this good drug here that, if you break even, fine, but you're making your money on another drug, and that's a $3 drug rather than a $300 drug.
Yeah, there's so many variables, not just in the prescription, in the healthcare world generally in the United States, but that's, I think, why we're at the forefront, because there's bad actors, and we don't want bad actors, and pharma's even drop members over bad acting and price gouging, and we oppose price gouging. But part of the reason that there's so many actors is because the United States, and I know most North Dakotans would agree, support entrepreneurs and the development of ideas into new products or services, especially when they help people, as is the case of medicine. So, yeah, there's these horrible cases, but if we can get the word out more about these patient assistance programs, which again number almost to 1,000, I think that it's better if people know about that.
Yeah, certainly in the last 5 years, the insulin and the EpiPen cases have been the two worst black eyes for the industry, I'm sure, and a lot of that comes down to what used to be called vulture capitalism, and people buying up companies, hedge funds buying up companies, and trying to take whatever they can from them and dump them in the ocean afterwards. But yeah, it's definitely there needs to be more positive interaction, and I would suggest that obviously with these bills and the votes that they've gotten, the industry needs to pay a lot more attention to North Dakota going forward. That's for sure.
Yeah, we've seen odd provisions in the bills that have been introduced in North Dakota over the last couple months. Some that would require a state to do business, a manufacturer, which is a private business, to do business in the industry. That, in other words, not be allowed under state law to pull out of any product out of the state. Secondly, there's also been language that's been introduced in these bills that would require not just a registered agent in the state for the private business, a manufacturer, but require a physical presence, a bricks and mortar physical presence in the state to do business. And if that's not government overreach, I don't know what is.
Definitely, and obviously, about our 51% rule for pharmacies. That law has been in place since the 60s, and that's right down there at the retail level. So a lot of this is that old populist protectionist policy migrating up the food chain, I would say, and people thinking that that's the solution. I mean, if they want companies to be headquartered here, they need to be more conducive to a business climate and that sort of thing, and maybe they'll come here.
Well, both the Dakotas, North and South, certainly have a leg up on Minnesota in that regard, and probably will in the foreseeable future, if they are able to keep their free market ideas intact.
Yeah, and obviously that's less of a sure thing now than any of us thought, I think. And It's amazing how fast things have changed in the last 6 years. That's for sure.
It's crazy. It's just crazy.
Well, with that, if you have any final thoughts,
I just like your EIB microphone. If you
you
so,
got the reference.
well, of course I do. I've been around a long time, and I used to call into talk radio shows when I was a teenager in the '90s. So I totally get it.